Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to hear a debate on oral treatments for psoriasis and psoriatic arthritis. This activity is jointly provided by Medical Education Resources, MER, and the International Dermatology Education Foundation. It is also an activity that's supported by an educational grant from Bristol Myers Squibb. Our meeting chair this evening is Dr. Leon Kircik, who's president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director at Physician Skincare, Derm Research, and Skin Sciences. Our speakers this evening is Dr. April Armstrong, who is professor and chief of dermatology at UCLA Health, Professor of Dermatology, Associate Dean for Clinical Research, Director of Clinical Research Support at Southern California Clinical and Translational Science Institute, as well as Dr. Mark Lebwohl, who is Professor and Chair Emeritus, Kimberly and Eric Waldman Department of Dermatology, Icahn School of Medicine at Mount Sinai, and Dean of Clinical Therapeutics at the Icahn School of Medicine. Again, this activity is supported by an educational grant from Bristol Myers Squibb. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues or if you would like to ask a question of our faculty, please type in your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. And finally, a certificate will be issued upon completion of this survey. Again, if you want to submit questions to our faculty, submit their questions using the question chat pane on the right-hand side of your screen. And I wrote a note there so you can know exactly where to type in your questions. So this educational activity is targeted towards physicians, physician assistant, nurses, nurse practitioners, and other healthcare professionals. Psoriasis and psoriatic arthritis is a misunderstood and underdiagnosed disease state in dermatology. For a very long time, we did not have clinical tested FDA-approved treatments for psoriasis or psoriatic arthritis. With the advance of new FDA-approved therapies that are rigorously tested in randomized double-blinded, placebo-controlled, multi-center clinical trials, there is a tremendous unmet need and a gap in the education of dermatology providers for patients with psoriasis and psoriatic arthritis. The objectives of this evening will be to review unmet medical needs in managing moderate to severe psoriasis and psoriatic arthritis with a focus on skin-related issues significantly affecting lesion clearance, non-adherence, associated comorbidities, and the necessity for more effective and well-tolerated treatments. To also differentiate the efficacy, safety, and selectivity profiles of interventions, particularly those targeting the JAK enzyme family, and discuss an overview of recent and continuing clinical trial pertaining to new entities, oral small molecule therapies for patients with moderate to severe psoriasis and psoriatic arthritis. And finally, identify qualified candidates for oral small molecule therapy and create customized treatment protocols that consider patient preferences, safety, and effectiveness. In support of improving patient care, this activity has been planned and implemented by MER and International Dermatology Education Foundation. MER is jointly accredited by the Accreditation Council of Continuing Medical Education, the Accreditation Council of Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. This activity was planned by and for the healthcare team, and learners will receive 1.5 interprofessional continuing education credits. For physician credits, so we're looking at 1.5 AMA PRA Category 1 credits. For nursing credits, we're looking at 1.5 ANCC Nursing Contact Hours. And for physician associate credits, we're looking towards AAPA Category 1 CME. This activity is designated for 1 AAPA Category 1 CME credits. MER ensures balance, independent objectivity, and scientific rigor in all of the educational activities. In accordance with this policy, MER identifies all financial relationships with the instructors, content managers, and other individuals who are in position to control the content of the activity. So the faculty has reported the following financial relationships, and the content managers have reported the following financial relationships. Our speaker disclosures are as follows for Dr. Mark Lebwohl, and as follows for Dr. April Armstrong. The content and views presented in this educational activity are those of the authors and do not necessarily reflect those of MER, International Dermatology Education Foundation, or Bristol Myers Squibb. The authors have disclosed if there is any discussion of published and/or investigational uses of agents that are not indicated by the FDA in their presentations. A certificate will be issued upon completion of an evaluation survey. Credits must be claimed by December 1st. The link will be emailed to you within 1 to 2 days of this webinar. And if you have any questions, please contact mremy@mer.org. You might want to take a picture of that. There is no fee for this educational activity. So without further ado, I will pass the floor now virtually to Dr. Kircik.
Thank you, Roxanne, for that very extensive introduction. And good evening, everyone, and welcome to another series of IDEF educational series. Tonight, we really have a very special program, but before we go there, I'd like to tell you a little bit about International Dermatology Education Foundation. IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. And since the COVID pandemic, we have been serving to our audience in many different areas. And as you can see from some of our invitations, past invitations, we have been all over the world, not only in US, but in Canada, South America, Europe, as well as Southeast Asia. So tonight, as I mentioned, we have a very, very special program, and please do follow us on LinkedIn, Instagram, and Facebook. Tonight's program, first of all, it is a CME program, and we're gonna have a debate on oral treatments for psoriasis and psoriatic arthritis. So this is really gonna be very unique, and I have as a guest speaker, 2 of the most brilliant minds in dermatology. We have Dr. Mark Lebwohl, who's my mentor and who's one of the biggest psoriasis expert, as well as one of our very much rising stars in dermatology, Dr. April Armstrong, who's the chairperson at UCLA. So first we will listen to their debate on oral treatments for psoriasis and psoriatic arthritis. And I'm very proud to present Dr. April Armstrong. She is the professor and chief of dermatology at UCLA, and Dr. Mark Lebwohl, who is also the professor and chair emeritus at Mount Sinai Medical Center Dermatology Department. Welcome, Mark. Welcome, April. Please take it from here.
April, I think you're on mute. Can't hear you.
Just click the little red microphone next to your name. There you go.
Oh, there we go. Oh, okay, awesome, great. Wonderful. So you can hear me now?
Yes, we can.
Excellent. Okay, great. It's such a pleasure to be here, and I'm really honored to be invited and to be doing this program along with Dr. Lebwohl as well as Dr. Kircik, and I think we're going to have a great discussion. I know the title says it's a debate. I would be very foolish to try to debate anything with Dr. Lebwohl, so I think we'll have a wonderful discussion here. Next, please. So today we're going to talk more specifically at oral therapies that are currently approved, FDA approved on the market. And we're going to take a closer look among them, the TYK2 inhibition, but we'll also cover, for example, our PDE4 inhibitor, apremilast, as well as some of the emerging TYK2 inhibitors. Next, please. So one of the things that I know our field has been asking is what patients are good for oral therapies? And when I think about this, next slide, I think about, first of all, therapies that might be good for everyone with regards to systemic therapies. So when we think about oral therapies as well as biologics, I oftentimes think about this guideline by the International Psoriasis Council, where we think about systemic therapies in one of three types of patients. Number one is that patients who may have a large BSA, 10% or greater. And we know that our payers oftentimes require BSA 10% or greater for our insurance approval. Or, and this is very important, disease involving special areas. And we're going to hear some of the data with regards to oral therapies involving special or high impact areas. And then finally, there's a failure of topical medications. And those are patients that could be really, we can consider for systemic therapy. Now, some of our patients, in my opinion, oftentimes prefer oral therapy. Other patients prefer biologic therapy, but these are areas that we can think about to begin with. And maybe I'll just get Dr. Lebwohl's take on this particular guideline from IPC, and to see if you have anything to add there.
I think this is a really good guideline because what it does, it expands the use. It's not just that patients have less than 10% body surface area for that forces them into topical therapy. If they fail topical therapy, or there are areas that are, what if it involves their face or severely involves their scalp, and you know that topicals aren't going to be good enough? Pretty quickly, you should be able to move to a systemic therapy. So I like the guidelines.
Yes, absolutely. And I think recently the IPC just published some guidance on what considers topical failure. And they think that 2 consecutive periods of 4 weeks use of topical therapies may be something to consider. And then we'll go to our next slide, which shows the proportion of patients who may have moderate to severe plaque psoriasis, but who also may have high impact areas that are involved. So what we learn from this is, for example, over half of our patients oftentimes have scalp disease, and about a third of them has some facial psoriasis, and about a quarter, about 20% to 25% may have genital disease, may have nail disease, for example. And importantly, most of our patients actually will have at least one sensitive area involved, and many of them will have 2 high impact areas involved. And I think those are really critical to keep in mind as we treat our patients and ask about if they have genital involvement, and look for signs of involvement in the scalp, look for signs of involvement in the nails, because those particular high impact areas can potentially elevate them for consideration of systemic therapy. And so on the next slide, I'm going to pose a question to Dr. Lebwohl, which are, what are some of the challenges with traditional oral therapies? And if I could love to get your thoughts on that, that would be great.
Sure. So by traditional oral therapies, I assume you're talking about acitretin, methotrexate, and cyclosporin. So methotrexate, if you ever looked at the box warnings, it's got more than 10 box warnings. You know, embryo-fetal toxicity, but you know, the things that really get our patients are not the liver changes, it's actually bone marrow toxicity. And there's a beautifully done study published by a group of rheumatologists that looked at all of the controlled clinical trials where methotrexate was used in low dose, usually 7.5 milligrams a day, a week rather, 7.5 milligrams a week, even lower than what we use, for rheumatoid arthritis, and the rate of pancytopenia or death was 1.4%. That's a real number. That means if you've treated 200 patients, there will be almost 3 patients who you either killed or almost killed. And And so methotrexate is a very challenging drug. It's one that I honestly lose sleep over when I have patients on methotrexate. It's got many drug interactions, which are part of the reason for that death rate. So a very tough drug to give. It's immunosuppressive. It makes you feel nauseous. It's got a lot of downsides. Cyclosporin, basically the guidelines, which I wrote decades ago for dermatology, said if you're going to be on this drug for more than a year, then you should not be on the drug for more than a year. Actually, that was imposed upon us by the FDA. If you're on it more than a year, basically 100% of patients have evidence of nephrotoxicity on kidney biopsy. So the guidelines said not more than a year for cyclosporin. It also causes high blood pressure and numerous other side effects, and has a lot of drug interactions as well. Acitretin, of course, by itself as monotherapy for most forms of psoriasis is not very effective. In addition to not being very effective, it has teratogenicity as a serious risk, and it causes a whole host of mucocutaneous side effects that our patients hate, including hair loss, chapped lips, dry skin. The hair loss is a major one. So the bottom line is that, and it raises lipids, a lot of other side effects. So the bottom line is that traditional oral therapies were just inadequate. And as you know, fortunately, we have some newer drugs that don't have those toxicities and might be more effective.
Yes, I completely agree with that. I would say that it's probably unusual these days to reach for methotrexate unless there is an access issue with some of our more advanced oral therapies. And I think if this were a debate of advanced therapies versus traditional therapies, then I think in most cases, hands down, I would say we are really looking for and then reaching for more advanced therapies. And we'll go to our next slide. And I wanted to see if Dr. Lebwohl can talk about if there are any remaining unmet needs in terms of accounting for patient preferences, because some patients may prefer, for example, phototherapy or injectable therapy or topical therapy, and thinking about those other modalities that are there. I was wondering, Dr. Lebwohl, if you can comment on, are there any unmet needs when we think about eliciting patient preferences or discussing with them regarding their preferences?
Yeah, so I think the first time a patient comes to your office, if they have more than 10% body surface area, for example, reaching for a topical therapy is something they might not be surprised at, but don't kid yourself, it's not going to be enough. You know, it's very difficult to treat even 10% or 8% body surface area. Once you start exceeding that, it's simply an impractical therapy. So then the choice becomes, what else can you give them? And if you mention injections, I thought, my goodness, what kind of doctor is this the first time I'm seeing him? Oral therapies are well accepted for many things. And lastly, phototherapy, to come in 3 times a week for months, again, is something that the first time a patient comes to you, they're simply not going to accept. Now, patients who have failed other treatments or have lived with psoriasis for a while will actually consider any of the non-topical therapies for extensive disease. And so they all become viable options. But you know, certain patients will simply refuse an injectable therapy. Other ones who have tried an injectable therapy and realized that it's really not that complicated to give yourself an injection and doesn't hurt that much might be more amenable to taking it. But oral therapies is something that everyone can accept.
Yeah, I think those are great points. I will say that one thing that I oftentimes, when I discuss the various options with my patients, is also ensure that they also understand the frequency of administration. And so, for example, some of our oral therapies are once daily, some maybe twice daily. And then we also have our injectable therapies, which can vary from every other week to as infrequent as once every 3 months. And that may play a factor in terms of their decision-making process in the overall shared decision-making process with us. Great. And then on the next slide, we are going to transition to taking a look at the intracellular pathways in psoriasis that are important. And why we're visiting intracellular pathways is because when we think about our small molecules, and those are typically our oral therapies, they target intracellularly. So that they make a distinction oftentimes between the biologics, which are overall are target things that are extracellularly or on the cell surface, on the extracellular side of the cell surface, versus our small molecules tend to target intracellularly. So we're first going to talk about the pathogenesis of what's going on in psoriasis intracellularly, and then we are going to take a look at the MOA of our approved therapies. So next slide, and this will be a rhetorical question for myself, and is if I'm going to talk about some of the key intracellular players that may be important in psoriasis pathogenesis. I know you're all dying to hear this, and so we're going to dive right into this. So next slide. When we think about the different pathogenic mechanisms that are involved in psoriasis pathogenesis, and this was an article that our group published in JAMA back in 2020, but still quite relevant, and it highlights the key pathways. You'll notice there are 3 key pathways that are highlighted, but we have known as a field that the middle pathway, the Th17 pathway, is most important. But for the Th17 cells and its downstream cytokines to affect their changes, IL-23 is actually this master regulator, sometimes we call it in psoriasis, that help initiate the process. And then with the action of IL-23, our Th17 cells can proliferate, can survive, and then can also express downstream IL-17 and a number of other factors. So while we think about the kind of the middle purple cell pathway that you see as Th17, we also have contributions from some from Th1 pathway, some from Th22 pathway. And these lead to then the proliferation of keratinocytes, and keratinocytes actually have some feed-forward mechanism where they can elaborate certain cytokines in order to perpetuate this inflammatory cascade. Next slide, please. So when we think about the different inflammatory cytokines that are floating in the extracellular space, the next question is, how do these cytokines then transmit their effects through the cell? Here you will see that there are a number of different intracellular signaling molecules. And when we look at them below that orange cell membrane, you'll see TYK2 is one of them. And in addition to TYK2, we also have JAK1, 2, and 3. And then 4 of these molecules are a part of the Janus kinase family. But you'll notice that TYK2 is a bit different from the others. The name is different. It was actually discovered first. And also functionality can be quite different as well. So for simplicity purposes on this particular slide, what we're looking at is the TYK2 pairing with JAK2 can be helpful in terms of transmitting the intracellular signaling pathway of IL-12 and 23. And then we also have TYK2 partnering with JAK1 is important for transmitting the signaling of interferon alpha and interferon beta. But your question is probably going to be, well, tell me where these cytokines are actually in the psoriasis pathway and how do these all line up? When we go to the next slide, we will be able to show you what that looks like. So here we're looking at the psoriasis pathogenic pathway, starting from the signaling of type 1 interferons. And type 1 interferons include interferon alpha and interferon beta. And they are very important. As you can see, they're depicted as this pink cell on the left-hand side. And that activation and signal transduction later on then leads to the secretion of IL-23, for example, by myeloid dendritic cells. Then IL-23, the purple molecule here, purple round dot, it can then bind to its receptor. And through the action of TYK2 and JAK2 here, then it can lead to elaboration of IL-17 and then downstream proliferation of keratinocytes. So the key thing I want to highlight here is that when we look at this particular pathway for psoriasis pathogenesis, TYK2 participates not only in the beginning, which is IL-23, but the very beginning, the beginning of the beginning, as I like to call it, in type 1 interferon alpha and beta signaling as well. And that's why it can, oftentimes when we think about this analogy of having a faucet and the water afterwards, so it's really working on the faucet aspects earlier on in the pathway in order to be able to initiate, in order to really initiate and perpetuate the psoriasis pathogenesis. And that's why when we're thinking about targeting of the various molecules, TYK2 is one of the ideal molecules, intracellular molecules to go after, because you're really going after the initiation of the psoriasis pathogenesis. Okay, so with that in mind, next slide, please. I'm going to pose a question to Mark. Mark, what are some of the current FDA-approved advanced oral therapies, and how do they work? And I'll have Roxanne go on to the next slide while we get your thoughts on that.
So these are the two, deucravacitinib and apremilast. There are a few more coming, hopefully fairly soon. But deucravacitinib is the TYK2 inhibitor, key molecule that you just heard about. Apremilast is a PDE4 inhibitor. One of the benefits of apremilast, phosphodiesterase inhibitors are well known. Caffeine, for example, is a different phosphodiesterase inhibitor. So both of these appear to be quite safe, as you will see from the data we're going to present. They are both approved for moderate to severe psoriasis and patients who are candidates for systemic therapy or phototherapy. They are also both approved for active psoriatic arthritis. Deucravacitinib is approved for adults. Apremilast is approved for a pediatric age group 6 years and above with a moderate to severe plaque psoriasis. Apremilast is twice daily. Deucravacitinib is once daily. Very recently, an extended release form of apremilast, 75 milligrams, was approved as a once daily pill as well. I should say apremilast also has been studied. I'm not sure if it's approved yet, but studied for more limited disease, less than 10% body surface area. Next slide.
I think those are really great points. And when we're thinking about when people think about, the debate of apremilast versus deucravacitinib, some of the foundational differences in the indication, and then also with regards to the age group differences is important as well. The apremilast down to age 6, as you talked about, apremilast for any severity, whereas deucravacitinib moderate to severe. I think those are all important distinctions. Next slide, please.
So, here you see the reason why deucravacitinib is so specific. The JAK1, 2, and 3 inhibitors bind to the ATP binding site, which you see on the blue substance that's outlining all of the JAKs. In contrast, deucravacitinib binds to the regulatory domain, inhibiting only TYK2 with very little effect on JAK1, 2, and 3, whereas JAK1, 2, and 3 also can inhibit TYK2. Let's go to the next. And what you see here are the different JAK inhibitors that are all approved. Tofacitinib is approved for psoriatic arthritis. Upadacitinib is, of course, approved for psoriatic arthritis. Baricitinib is not approved for psoriasis or psoriatic arthritis in the US, but has many uses, including alopecia areata in the US. Deucravacitinib, of course, is approved for psoriasis and psoriatic arthritis. Now, look at the amount of inhibition by the JAK1, 2, and 3 inhibitors of all of the JAK activities, and notice that the only one that dramatically inhibits TYK2 is deucravacitinib, and that it has very little impact on JAKs 1, 2, and 3. So it's a very targeted, very focused. It is called a JAK inhibitor, but it's actually, in fact, when the brand name was given to it, it so dramatically blocks TYK2 as opposed to the others that they incorporated that into the product name. Next slide. So other head-to-head studies, and I'll ask and answer this question. There's a beautifully done study published in The Lancet comparing deucravacitinib and apremilast, very important study. Next slide. And so these studies were called the Poetic SO1 and Poetic SO2 trials. They're identically designed studies where they compared deucravacitinib 6 milligrams a day to apremilast 30 milligrams twice a day, or placebo. And what you see is that during the first 16 weeks, the studies are blinded. After that, the placebo arm is discontinued, and I believe there was a crossover. So what you see here is that at week 16 in both of the studies, deucravacitinib is substantially more effective than apremilast or placebo. In SO1, it's 58.7%. Achieved the primary endpoint, which was PASI 75, compared to 35.1% of the apremilast patients, 12.7% of the placebo patients. And the numbers were a little bit closer, a little less dramatic in SO2, but again, deucravacitinib is statistically significantly more effective than apremilast or placebo. Of interest, and you see this a little bit more in the SO1 trial than the SO2, but this actually is what we see in clinical practice. The patients do pretty well by week 16, but notice it's a little slow getting there. At week 4, the proportion of patients achieving past 75 is not that high. By week 8, that increases, even more by week 12, and of course we have decent results by week 16, but notice that is not the peak. The peak is actually at week 24, and actually the trajectory is even going up at that point. In clinical practice, what we find is the peak effect is at 6 months, at week 24. And I actually tell that to patients when I give it to them, so that they don't over-expect. They don't expect to be better in a few weeks. It's a slow drug. It takes 6 months to peak. Next slide.
Yeah. So maybe
please.
I'll, so I think you cover all the great points on this slide, Mark. I think the key thing is that I also tell my patients, especially during the first few weeks, I say the drug deucravacitinib is working steadily for you, and you should continue to see improvement. So I know many of our patients, or us, we're used to, for example, for some of our biologics, the onset can be rather quick. And I think helping our patients to understand during those first few months that they will see improvement and steady improvement, and that they should continue to see improvement over time is important. So that setting that expectation for them, so that they are they're not expecting, for example, dramatic improvement during the first week or something, will be important for adherence.
So I have a question. Do you add something during this period, guys? Do you add some topicals maybe? Do you add phototherapy to make that a little bit easier and faster for the patients?
I always have them on topical therapy, always. I don't tend to add phototherapy unless for very select circumstances, I would say. So I would say definitely topical therapies, and also expectation setting can actually go a long ways. So if I see them back in 3 months, I say, in 3 months, I definitely don't expect you to be at the peak of how well the medication can do for you, but mainly just to make sure you're tolerating everything, and that most importantly, that you actually got the medication. So
Yeah.
Same answer, identically. A high proportion of the patients are indeed using topical therapy. Of course, it depends on what part of the body and extent of the body is involved. You can't really put topical therapy on the whole body when you have a patient with severe disease or very extensive disease. But you can certainly put it on the face. You can treat the scalp. You can treat visible areas with topical therapy.
Yes.
Thank you.
Thank you. And then maybe we'll go to the next slide. So next one talks about the long-term persistence data for deucravacitinib. I think Dr. Lebwohl went over really nicely the placebo-controlled and apremilast-controlled piece. And here, longer-term data, the apremilast arm goes away, and then what we see is that now 5-year data for deucravacitinib. And what you will notice is that over the time of these 5 years, if a patient had been a responder to deucravacitinib, they tend to respond and maintain that response pretty well. So about 70% of the patients will maintain PASI 75 over about 5-year period of time. So I think, yeah, there's durability from oral medication. Yeah, what do you think, Mark?
I agree completely. I will say, notice that the percentages go up a little bit. Notice also that when you have a really effective drug, the as observed and the non-responder imputation lines are pretty close to one another, and that is the case here. It's a drug that really works well, keeps on working, even works a little bit better at week 52 and at week 256 than at week 16, even in the MNRI group.
Mm-hmm. Yes. Yeah.
I think one thing here, it's really impressive that MNRI starts from baseline from week 0, right? Most of the studies you see, the MNRI starts after the primary endpoint. It's sort of the cherry picking. Here you have that MNRI from week 0 baseline. So I think that's really impressive.
Yes. Yep. Yeah. And then we'll go to the next slide, and perhaps Dr. Lebwohl, you can comment on the AEs of interest, so adverse events of interest, and what they showed during the first year for deucravacitinib.
Yeah, and these are all the adverse events that we look at with systemic drugs that might impact the immune system or might have JAK inhibitor type side effects. So are we worried about cancer? Well, I've already told you that apremilast is has a mechanism sort of similar to caffeine. It's been around a long time. We know it's not associated with an increase in malignancy, and deucravacitinib comes in pretty close to apremilast on non-melanoma skin cancer. Same for malignancies that are not non-melanoma skin cancer. Same for serious infections. You wouldn't expect coffee to give you an infection, and that may not be a fair comparison because it's not the same phosphodiesterase enzyme. However, we know that apremilast is not associated with an increase in infections. Deucravacitinib has the same rate. Interestingly, herpes zoster, there is a not statistically, maybe barely statistically significantly compared to apremilast, but there is a tiny increase in herpes zoster on the order of 1 per 100 patient years. So that is one that I actually do mention to patients at the time that I prescribe deucravacitinib. As for arterial and venous thromboembolisms, there's no increase. There barely any occurred and no increase at all. And as far as cardiovascular events, the rate's lower than the placebo rate.
Yes, yeah.
Do you guys vaccinate your patients for zoster before you start?
So I will say it's not required. Having had one patient who developed herpes zoster on deucravacitinib, I actually do. I do actually recommend it to my patients for deucravacitinib and for any of the JAK inhibitors.
Yeah, I do too. Yeah. April?
I do it differently. I definitely, I universally ask my patients to get vaccinated for the JAK 1, 2, and 3 inhibitors, but I do not require my patients to get vaccinated for zoster. And this is because some of the longer term data have shown that the zoster rates for deucravacitinib are very similar to the background rates that we see for patients with moderate to severe plaque psoriasis on biologics. So at the population level, I think the rates are very similar. But of course, you can get a patient who's unlucky and can get that. So
yeah, and I agree. Even looking at this one where the increase is minuscule, that would not push you to get Shingrix vaccines. But I guess personal experience that bothered you a lot is the reason that I do it.
Yeah, I can understand. Great. So now we're going to shift gear a little bit and let's go to high impact areas, or sometimes formerly called special sites. And let's take a look at the next slide, which shows the Poetic
Yeah.
PSO 1 and 2 studies. So these are the pivotal studies that looked at patients with generalized plaque psoriasis who also happen to have plaque psoriasis on the scalp that are moderate to severe. So in the pivotal studies we just presented, this particular analysis looks at the scalp specifically in those patients with generalized plaque psoriasis, and then track them over time. And what you see is that by 16 weeks, those who have had moderate to severe plaque psoriasis overall, if they were randomized to the deucravacitinib group, about 70% of them would achieve clear or almost clear scalp, versus about 39% in the apremilast group for Poetic PSO1 study, and similar findings in Poetic PSO2. So almost twice the efficacy in terms of scalp clearance for deucravacitinib as opposed to apremilast for this study for this portion up to week 16. And on the next slide, we will see what happens after week 16. And what we'll see is, I'll wait for the slide to change. Here, what you see is that at week 16 and afterwards, you see a maintenance. So you see the group, you see the deucravacitinib group reaching 70% of clear, almost clear by week 16 of scalp disease. But then you follow them over time, and what you see is that good maintenance of response over time. And now we're going to shift gear, and Dr. Lebwohl is going to talk to you about a different study that looked at scalp-only disease, so patients who have severe scalp but not much plaques elsewhere, which, as we know, is actually a different phenotype and a more difficult to treat phenotype. So next slide, please.
Yes, so scalp only often does not respond as well, and as April said, it is more difficult to treat. But look at the numbers here of clear or almost clear, and even a scalp severity index of 90% improvement. And you're looking at close to 40% for the PSSI 90, for clear or almost clear, 48.5% compared to 13.7% for placebo. And then the one of the worst things about scalp psoriasis is the itching. And when they look at specifically a numerical response scale on a 0 to 10, what's considered significant is a 4-point reduction or more. And at week 16, you see that over 40% of the deucravacitinib treated patients do reach that endpoint for scalp itching. So very dramatic, even in scalp only patients who are notoriously more difficult to treat.
Great, terrific. So we talked a lot about skin. We're going to shift gear a little bit. Next slide. We are going to think about psoriatic arthritis, which is a very important part and piece of the psoriatic disease. And I'll have Dr. Lebwohl talk a little bit about the deucravacitinib efficacy in PSA in their Poetic PSA trial on the next slide, please.
So what you see here in blue is the deucravacitinib 6 milligram a day arm. That's in dark blue. In light blue, apremilast 30 milligrams twice a day, and then the placebo arm is switched to deucravacitinib, and that's going to be shown to you in green. So at week 16, you see that deucravacitinib outperforms apremilast for psoriatic arthritis, although that is not that is statistically significant. The p-value is I'm sorry. For deucravacitinib to placebo is statistically significant, but not deucravacitinib to apremilast. I don't believe there. And that's looking at ACR 20. You see in the second series of bar graphs, ACR 50 again, deucravacitinib beats both other drugs, and then again in ACR 70 where you see it beats it. And it does at all time points, week 16 and week 52. The improvement at week 16 is substantial. It increases even further through week 52, but remember that period is not placebo controlled.
Yes, yeah, I think those are good highlights and key points to recognize. I think probably the take-home message from here is that even though it's not yet approved, even though deucravacitinib is not yet approved for PSA, we see that it has efficacy on psoriatic arthritis, and we anticipate probably PSA indication hopefully very soon. Next, please. So we're gonna switch gear and really think about apremilast in PSA. But before we go to look at that data specifically, just as a reminder that apremilast's approved indication are listed as follows. One is not only in patients with moderate to severe plaque psoriasis. Initially, that was the indication, but later on it transitioned to regardless of psoriasis disease severity. So if you have a patient even with mild, for example, psoriasis, and if you think the patient is a candidate for systemic therapy, you can use apremilast. It's also approved in patients, adults with active PSA. And in addition to that, it is approved in kids 6 years and above for moderate to severe plaque psoriasis. And don't forget, it's also approved in patients with Behçet's disease to reduce recurrent oral ulcers. And the dosing that's used for Behçet's is the same as that used for plaque psoriasis. In the vast majority of the patients, no laboratory monitoring is required. One thing is that if your patients do have very severe renal insufficiency, then you may want to decrease the maintenance dose from 30 milligrams BID to 30 milligrams QD. Some of the side effects of apremilast include diarrhea, nausea, headache, weight loss, and so forth here. But the initial week where you have the dose titration, hopefully that will get some of your patients a bit more used to taking the medication. Next slide, please. So with that in mind, let's take a look at the apremilast PSA data. So in the PALACE studies, which is apremilast PSA data, they looked at adults with active psoriatic arthritis, including those with a prior DMARD or biologic exposure. And the primary endpoint here at week 16, for example, ACR 20 response were achieved here for different doses. I'm going to have us actually focus on the green lines because those are the apremilast 30 milligrams BID, which is the approved dosing for psoriatic arthritis, similar to psoriasis. And what we see is that at week 16, ACR rate 20 rates were significantly higher with apremilast 30 milligrams twice daily, and then depending on the trial, anywhere between 32 to 41% compared to the placebo, anywhere between 16 to 19%. In addition to that, which is not shown here, but we also show there were also improvements in the physical function, enthesitis, dactylitis, as well for apremilast in the PSA studies. Okay, and next slide, please. And here I'll have Mark talk a little bit. Can you talk a little bit, Dr. Lebwohl, about the advantages of TYK2 inhibition that we mentioned earlier?
Yeah. So as you know, 2 other JAK inhibitors are approved for psoriatic arthritis. This drug has no box warnings, unlike methotrexate, cyclosporin, and acitretin. Apremilast also does not have box warnings. There are no significant drug interactions for deucravacitinib. It is very well tolerated, very few side effects, unlike apremilast, which has a lot of GI side effects and weight loss as a common side effect, and headache for that matter. It is efficacious, more efficacious than apremilast. It approaches the efficacy of some of our biologics, but certainly not of our newest IL-17 or 23 blockers. It has a similar safety profile after 5 years compared to 1 year. And basically, the rate of adverse events do not appear to go up over 5 years. It is available in a pill form, doesn't have to be taken with or without food, unlike some drugs that are in development that need to be taken with food. it does not require any laboratory monitoring other than a TB test at baseline. And in the setting of a patient with liver disease, liver function testing is recommended. It has superior drug clearance, and it approves many comorbidities of psoriasis. In fact, it has been one of the most effective treatments we have for lupus, which is an interesting observation. Okay, next slide. Oh, April, did you want to comment?
Yes. Oh, I was going to comment on that, on the lupus comment that you made. Absolutely. I think newer data that were revealed recently showed efficacy of deucravacitinib in different forms of lupus. So I think this is really, really exciting because I think that for a long time we haven't really had efficacious and safe options for especially SCLE, which is in our dermatologist realm. And so seeing some of those data, I think is very exciting.
Yep,
and with that, and then we're going to transition on to the additional selective TYK2 inhibitors here. So in addition to the approved deucravacitinib, we do have 2 molecules that are in late phase development, also TYK2 inhibitors. And the key thing about these 2 is that I think as a field, we're going towards even more specific targeting of the allosteric domain, the JH2 domain of TYK2. And the purpose of that is so that we can raise the dose so we can be more efficacious while maintaining the safety. So see if we can get even stronger than existing medications. So there's the zasocitinib, which is in late phase development, and then their ESK-001. So let's go to the next slide, and I'll show you some of the zasocitinib data, and then Dr. Lebwohl will later show you the ESK-001 data. Next, please. So here is the zasocitinib phase 2b data, and this was presented now at the AAD about 2 years ago now. And then what we see here is essentially looking at the both PASI 75 and PASI 90 response with zasocitinib. And what you see is that at the higher doses for PASI 75, by week 12, this is very important when we're looking at the endpoint. This is not week 16 data, but at week 12, you see about 70% of the patients achieving PASI 75. And also what's not shown here is the PASI 100 data, which is quite promising, which is what we showed in that is really looking at the PASI 100 and seeing a third of the patients is able to achieve clear by week 12. So I think this is really encouraging, and I look forward to seeing the phase 3 clinical data. Hopefully will be revealed soon. And then Dr. Lebwohl, can you comment on the ESK-001 data?
Yes, ESK, I think that's coming up next. Let's get the slide. ESK-001 has similar to other TYK2 data. Notice at week 12, so slightly earlier endpoint, you're looking at the highest of 64% achieving past 75, not that different than what we just saw, compared to 12% in the placebo group. And interestingly here, between weeks 12 and 16, where I guess they do have they're showing the placebo arm, but that was converted from placebo after week 12. Anyway, the bottom line is that the data at week 12 does appear to be close to what we were seeing with the other TYK2s at week 16. Next slide. There is data where they extended the ESK-001 for months, but it was not placebo controlled. So it seemed to really achieve levels we don't see with the other TYK2s. But again, I always caution, if there's no placebo arm, the patients always seem to do better. Yeah,
absolutely.
So, yeah. So in any case, we've got a great stories for our patients, and you need to know all this data because we have a lot of options. So Obviously, patient preference plays a role. Do they not want injections? Do they specifically want pills? Are they so conservative they only want topical therapy, even with extensive disease? Cost and access play major roles. If patients have done poorly with previous therapies, that helps us predict how well or not well they'll do with new therapies. Comorbidities play a major role. I just said to you, lupus is very effectively treated with TYK2 blockade. Well, it turns out that lupus is increased in patients with psoriasis a little bit. So if somebody happens to have lupus, or even you're concerned that they might have symptoms that might be predictors of lupus in the future, you might want to use a drug like deucravacitinib. The convenience of a pill versus an injection might weigh in here. Safety is important, and as I showed you, this appears to be quite a safe drug, as is apremilast, although apremilast has GI side effects. The efficacy in psoriatic arthritis might lead us to use it as an oral therapy for psoriatic arthritis, and its efficacy in skin disease for patients who, for a variety of reasons, are better candidates for an oral therapy, might do very well with both of these drugs, apremilast and deucravacitinib. Next slide.
Yes, I think that's a great summary there. And one of the things I know from my clinical experience using both of these medications, and when we think about TYK2 inhibitors, for example, for our approved TYK2 inhibitor, deucravacitinib, some of the things that came sort of rung true to me was that they're oftentimes more ideal for systemic naive patients. And they're more suitable for patients with a more moderate form of plaque psoriasis rather than the very severe form, and they can be highly effective for high impact areas such as the scalp. And then of course they're preferred for patients who desire an oral treatment. And next slide. I will very quickly go over the monitoring. So per the package insert or for the label, the only monitoring or testing required universally for everyone is a TB evaluation before you start deucravacitinib. However, if you do have a patient who may have known or suspected liver disease, you can check baseline LFTs and hepatitis serology. And for ongoing monitoring, none is required universally with regards to monitoring for deucravacitinib. And I think our understanding for that has really evolved over time. And most of this has been guided by the long-term safety data now that we have for deucravacitinib. And next. So to conclude, I think Dr. Lebwohl and I, we had a really nice conversation on the use of approved oral therapies, as well as looking at some of the upcoming TYK2 inhibition as well. I think that there's a lot of promise in terms of the TYK2 mechanism overall and continually. And I think having a personalized approach for our patients and a team-based approach when we're addressing their psoriasis and psoriatic arthritis and other comorbidities is likely the most ideal for our patients. And with that, speaking of team-based approach, really appreciate my time tonight here with Dr. Lebwohl and as well as Dr. Kircik. And I want to thank everyone so much for your attention. And if you have any questions, feel free to use the question pane on the right-hand side of your screen. Thank you.
Thank you very much, April.
We do have time for questions. Dr. Kircik?
Somehow I disconnected. Hello?
Yeah, we can hear you, but
Can
we
you hear
can't
me?
see you. We can hear you, but we cannot see you.
Okay. How about now?
Nope, not quite.
Okay, let's do without seeing me. So, in what situation are you recommending deucravacitinib over biologics? That's really a good question.
I'll start with that. When I have a patient with primarily palm and sole disease, biologics are not that effective. I would say the one that has the best data is bimekizumab. But if you look at the gesture study or the risankizumab palm and sole study, they just didn't do that well. I believe small molecules have an advantage by virtue of their size for palms and soles. We don't have the deucravacitinib palm and sole study public yet. We don't know the data on that, but certainly in clinical practice, I have found the small molecules, and in particular deucravacitinib, but also apremilast, to be more effective compared to the degree of efficacy we see on the body. So palm and sole is one area. The other time that I use a lot of deucravacitinib is actually off-label in combination with other biologic therapies. It says on the package insert not to be used with potent immunosuppressives. When I get a rejection from insurance companies, which I don't usually get, it's just a minority of insurance companies that will reject the combination. What I write back is that the biologic is not a potent immunosuppressive, therefore it is fine for me to use deucravacitinib with it. And we have found that combination to be fairly effective for many patients. So those are two circumstances where I use a lot of deucravacitinib.
Yeah, and I would add that the combination that I use also quite a bit in terms of deucravacitinib in combination with biologics for our a bit more recalcitrant to treat patients. And the combination that I find to be very helpful are patients who may be on an IL-17 biologic inhibitor, and then you add deucravacitinib, which inhibits IL-23 intracellularly. So having both the IL-17 pathway inhibited by the biologic and the IL-23 pathway inhibited intracellularly by deucravacitinib, that combination can be effective for some of our patients with just very recalcitrant to treat psoriasis.
Yeah, I would say also, we published a series of 20 patients. I think it was in the British Journal of Dermatology. And what we showed, even though you'd think that using it with a drug like risankizumab, which blocks IL-23, that it's the same mechanism, we found that it was additive and that actually all of the patients had an additional benefit by adding on deucravacitinib, whether they were IL-17 or 23 blockers.
How about this one? Have you found Sotyktu to be more effective than biologics for scalp disease specifically?
I think, I think I find Sotyktu to be quite effective in scalp disease. However, whether it's more effective on scalp disease, I would say that it's a bit variable. So sometimes I find some of the biologics work quite well for the scalp disease. So I would say that one, it may be a bit more individualized response there.
I agree. In the study, was there no risk of elevated triglycerides or CBC changes? This is for Sotyktu.
So when we're looking at the laboratory tests, and then now we have 5-year data, so that's extremely helpful and instructive. What we see is that overall, when we're looking at the population level, the overall there were no increased signal compared to the two norms that we see. Of course, there were a few patients where they had baseline risk factors for hyperlipidemia that we do see some elevations there. So I think the key thing is that, for our patients, as our psoriasis patients has a lot of comorbidities as it pertains to hyperlipidemia and so forth. So making sure that they still have their primary care, evaluating that and ensuring that aspect is taken care of is important. But there's no, the long-term data has not shown a signal at the population level for deucravacitinib.
Is apremilast the only systemic drug that has mild indication in the label?
That is so the label technically reads, label doesn't say the severity. So the label just say it's, it's indicated for anyone that you think would be a patient for a systemic medication. And so by interpretation of that, yes, the answer will be yes to that. At the current time, when we're thinking about all orals, all biologics, the rest of the label have the qualifier of moderate to severe in there.
Moderate to severe. And they did the study for mild, correct?
For apremilast, yes, yeah, they did do the
Yes.
study for mild to moderate.
Yeah. For psoriatic arthritis, either apremilast or Sotyktu, is it, do we know if it benefits, if axial disease benefits, or it's only for peripheral disease? Do we have data on that?
So the data, so first of all, I don't believe that they're specifically approved for axial disease. I may be wrong. I don't think it's in the
I don't think
packaging.
so, yeah.
The data for axial disease is strongest for TNF blockers and IL-17 blockers, not for IL-23, apremilast, or deucravacitinib.
Yeah, that's what I thought. And I don't think they have radiographic evidence, right?
No, neither of them have been shown to prevent the radiographic progression of joint disease.
Well, I think we ran out of all the questions, and I really think this was a great discussion, and we'll give some time back to our audience. We had planned this since till 8:30, but I think we've done it really efficiently. And so I thank you very much. I think this was very helpful, a very great session. I thank you both very much.
Thank you. Thanks, Leon.
Thank
Thanks,
you.
April.
Yeah, thank you.
Remember,
Take care.
everybody, you need to claim your credits by December 1st. And if you have any questions, please contact mremy@mur.org. Again, this activity was supported an educational grant by Bristol Myers Squibb. And now that this part of this session is completed, we'd like to invite you to the next International Dermatology Education Foundation series webinar. This webinar is going to be on Monday, November 17th, when we're going to talk about a breakthrough for hands for chronic hand eczema with Dr. David Cotter. So thank you all for joining us. Good night, everybody.
Night.
Thank you. Good night.
Good night.
Bye-bye.
Thank you.